Bismillah ar-Rahman ar-Rahim. Alhamdulillah wa salatu wassalamu ala Rasulullah. Happy to be here tonight. Thank you very much for Merck for organizing this session. I hope this will be of benefit to the audience and would be entertaining. So my name is Al Zahrani. I'm a consultant endocrinologist at King Faisal Specialist Hospital and Research Center in Riyadh. And the topic of tonight is management of hypothyroidism. So what we are going to discuss is how to diagnose hypothyroidism, when to treat subclinical hypothyroidism, which thyroid formulation should we use? Should we use T3 or T3 to T4 combination? We'll talk specifically about some special group, especially elderly and frail patients, or those with comorbid conditions. We'll talk about diagnosis and treatment of hypothyroidism in pregnancy. We will discuss briefly whether thyroxine can be used to decrease weight. So this is the outline of tonight's lecture. I hope it will be of great benefit. So as usual, clinicians love cases, and I will start with a case that I'm pretty sure you see it frequently in your practice. So this is a 44-year-old lady who came to you complaining of fatigue, constipation, weight gain, and low moods, common symptoms. Her clinical examination showed that she looked depressed. She had no clear hypothyroid signs, but what are the hypothyroid signs? It's very difficult to really pinpoint specific signs. She had no goiter. And the question is, do you think she is hypothyroid? How likely she is? Again, this is a common scenario that you see in your clinic. And I think the most pertinent question is whether a patient like this is hypothyroid. What is the likelihood? Should we test her thyroid function test? I know we don't have a voting system, but think about it yourself, and we'll come back to this question again. So this patient came with a bunch of symptoms, at least 4 symptoms, and the question, how good or how sensitive and specific those symptoms are for the diagnosis of hypothyroidism. This is a study that have shown in brief that these symptoms are common, not only in patients with hypothyroidism, clear hypothyroidism, or subclinical hypothyroidism in black, but also in normal people. So you can see that 0 symptoms are obviously common. Most of the people are not symptomatic, but you can find 1 symptom, and there is no difference between patients who are subclinically hypothyroid, overtly hypothyroid, or normal people. 2 symptoms, 3 symptoms, and 4 symptoms. So symptoms, in other words, are not specific. And especially the hypothyroid symptoms, they are very common. Constipation, tiredness, low mood, these are common symptoms and signs. Just a summary of this, that 60% of euthyroid patients, people who do not have any symptoms, they have more than 1 symptom, and about 15% of the population have 4 symptoms that suggest hypothyroidism, but they are not hypothyroid symptoms. They are actually common symptoms. And for this reason, it is not recommended that you treat any patients based on symptoms. This is from the American Association of Clinical Endocrinologists guidelines, saying that clinical scoring system for symptoms should not be used to diagnose hypothyroidism. In other words, we need lab to confirm this. Now, in a patient like ours, the symptoms are suggestive, but we have to confirm it. So the next question for a patient like this, which test would you use? And you have a series of tests here. You have TSH, FT4, T3, FT3, anti-TPO antibody, ultrasound of the thyroid, or thyroid scan. Again, answer it for yourself. We'll discuss it again. Which test should we use in a patient like this who presented with constipation, fatigue, weight gain, low mood, and so on and so forth. We'll come back to this case, but let's discuss in general what are the causes of hypothyroidism. And I'm sure you're familiar with this. The most common cause of hypothyroidism is autoimmune thyroiditis or Hashimoto's thyroiditis. This is the most common cause almost in every society. The other common cause that we see in our practice is patients who had thyroid surgery. Obviously, when you remove the thyroid, basically the patient becomes hypothyroid. These are the very common cause. Most patients who come to the clinic, if they have hypothyroidism, it is related to Hashimoto's thyroiditis, autoimmune thyroiditis. But obviously, if they had history of thyroidectomy, that would be the cause. If they had history of irradiation to the neck, that would be a cause. Rarely, patients may have hereditary or congenital anomalies or congenital absence of thyroid, or sometimes dysharmoniogenesis. But those patients, usually they have long history. They are more likely to be young children, and they are usually diagnosed. So for the most part, for adult patients coming to your clinic, like the patient we described, Hashimoto's thyroiditis is the main cause. Now, central causes, whether it's pituitary or hypothalamic, sometimes we call them secondary, referring to pituitary, and tertiary, referring to hypothalamus, are actually rare, and they have to be considered sometimes when the patient is clearly hypothyroid and there is no abnormalities. I mean, basically, the lab actually would suggest to you the central cause, as we will discuss in a minute. Now, recently, some drugs can cause hypothyroidism. I think we are more familiar with amiodarone and lithium, but there are some drugs that are used in cancer therapy. If the patient has cancer and is receiving any of those drugs or even antipsychotic drugs, they may manifest with hypothyroidism. So again, the most common cause in the clinic, more than 90% of the time, is Hashimoto's. If the patient has a history of thyroidectomy or irradiation to the thyroid, that's the cause. If the patient has a history of pituitary surgery or pituitary tumor, that could be the cause. And of course, the lab is different, as we will discuss in a minute. So what about testing for thyroid dysfunction? TSH obviously is an excellent screening test. So for a patient like ours, TSH will be the best next step to confirm or rule out the possibility of hypothyroidism. But we have also to recognize the shortcoming and pitfalls of TSH testing. So the first one, and probably the most important one, is if a patient has central hypothyroidism, pituitary or hypothalamic. Those patients will have either low TSH or normal TSH, but the FT4 is going to be low. So this is what we call sometimes inappropriately normal TSH, because if the FT4 is low, TSH should go up. This is a normal physiology. If it doesn't go up, then the problem is really in the central place, either hypothalamic or pituitary. These are rare causes of abnormal TSH, abnormal isoforms, TSH receptor polymorphisms. In our day-to-day practice, we don't usually think about them because they are extremely rare. But if you have a patient who looks normal and you have abnormal TSH, consider these things if you cannot substantiate the diagnosis of hypothyroidism. Drugs can affect TSH, especially in the hospital. Steroids, if a patient comes to you and he's on a large dose of prednisone or dexamethasone, that can suppress TSH. Dopaminergic drugs and other drugs like lithium and amiodarone. Again, part of the unusual and very rare things is heterophile antibodies. They can interfere with TSH. They can actually suppress it or make it elevated factitiously. Inpatient population, TSH is not a good test in the hospital. When I am consulted on a patient who is in the hospital and I want to assess his thyroid function, definitely TSH alone is not enough. So in those patients, typically I order TSH and FT4. because TSH is affected by illnesses. If the patient has any illness in the hospital, and usually patients in the hospital have illnesses, then TSH can be suppressed, can be elevated, what we call sick euthyroid syndrome. So in a hospital setting, TSH is not a good screening test. You should do TSH with FT4. Adrenal insufficiency may slightly raise TSH. So there are a number of rare conditions that you have to consider them when the clinical scenario is not consistent with the diagnosis of hypothyroidism. Most important probably is the central cause, although it is rare. But if a patient comes to you and he has history of head trauma, for example, or history of pituitary surgery, and you do TSH and it's normal, that does not exclude the possibility of hypothyroidism. You need FT4 in that situation. And typically FT4 will be low and TSH will be either low or inappropriately normal. Now, what about FT4 and TSH? Now, as you all know, total T4 and total T3 are affected by many things, especially estrogen, either in pregnant ladies or in ladies taking oral contraceptive pills. Sometimes there is a hereditary increase or decrease of the thyroid binding globulin. Diseases like liver disease, kidney disease can affect actually the level of the total hormone. Therefore, for many, many years, the free hormone hypothesis has been put there. In other words, we have to measure free fraction because the free fraction is the active fraction. The bound fraction, most of the thyroxine, more than 99% of the thyroxine and T3 are bound to thyroid binding globulin, to albumin, to prealbumin. But what is active is the small fraction that is circulating in the plasma, and therefore we would like to measure that. Unfortunately, we don't have a perfect test for that. The gold standard is what is called equilibrium dialysis, but this is very cumbersome test and is not widely available, and most of the time is used in research. Therefore, we resort to other types of estimates. And the estimates that we use, and I think most hospitals use and you are familiar with, is basically free thyroxine. And free thyroxine uses antibody against thyroxine to roughly estimate what is the free fraction. They are not perfect tests. They have their own shortcomings, especially in certain situations like pregnancy. But they are pretty good and reliable for the most parts. Therefore, we usually use them in combination with TSH. An old method, which is actually still good and is still used in some hospitals, is what is called free thyroxine index. And that depends on basically calculating the total T4 and the T3 resin uptake and then multiply them in each other and you get what is called free thyroxine index. Again, because of the ease of free thyroxine assays that uses antibodies, this is actually being phased out. So from a practical point of view, the test that we have is TSH as a good screening test and free thyroxine as supplementary and an important test, especially in inpatient situation. What about T3 and free T3? These tests are not good at all and should never be ordered to diagnose hypothyroid patients. So if you suspect hypothyroidism, T3 or free T3 are not good tests and they should not be ordered. So you may ask me what is the use of free T3 and total T3? We use them sometimes in patients with hyperthyroidism, high thyroxine, or high thyroid function, or hyperactive thyroid. Because in around 5 to 6% of patients with hyperthyroidism, you may not detect high FT4, what is called T3 toxicosis. So in that situation, you can order T3 if the TSH is suppressed or if the clinical scenario dictates that. So again, principal use is in diagnosing and following thyrotoxic patients, not hypothyroid patients. Free T3 especially is not a good test. I see it commonly ordered in the private practice, but free T3 is notoriously unreliable test and should not be actually used. If you are going to measure T3, is probably better to measure T3, total T3, and not free T3. And again, only in hyperthyroid patients, not in hypothyroid patients. What about antibodies? Antibodies actually are useful. They are markers of chronic thyroiditis. We have commonly two types of antibodies. We have the anti-thyroglobulin antibody, but this does not correlate usually with hypothyroidism. In other words, if you have a patient who is euthyroid, but his anti-thyroglobulin antibody is high, it does not necessarily mean that he will develop hypothyroidism in the future. In contrast to anti-thyroid peroxidase antibody or anti-TBO antibody, those usually are risk markers or markers of risk for development of hypothyroidism in the future. And they are actually markers of autoimmune process, autoimmune thyroiditis. So they are very, very useful, especially in subclinical hypothyroidism, as we will see in a minute. This is from the American Association of Clinical Endocrinologists guidelines saying that thyroid peroxidase antibodies measurement should be considered when evaluating patients with subclinical hypothyroidism. And the reason for this, when you have a patient with a slight elevation of TSH, but normal T4, you don't know if this patient is genuinely hypothyroid or this is just a lab error or diurnal variation or something like this. The presence of anti-TBO antibodies in this setting strongly support the diagnosis of subclinical hypothyroidism. Okay, let's look at this diagram, which actually shows you the natural course of hypothyroidism. So hypothyroidism in a way or another is similar to diabetes. And many of you see diabetic patients. Usually diabetic patients starts with normal blood sugar, normal hemoglobin A1C, everything is normal, preprandial and postprandial. And then they start with impaired glucose tolerance. And then with time, they develop frank diabetes. Thyroid more or less does the same thing. So in a patient who developed hypothyroidism prior to this, he is completely normal. And you can see his TSH, FT4, total T4, T3, everything is normal. Then if he has mild disease, if he has the inflammation in the thyroid, destructing thyroid cells, he starts to have mild thyroid failure, or what we call subclinical hypothyroidism. So you start to see TSH elevation, mild elevation, but normal T4 and normal T3. This situation of subclinical hypothyroidism is similar to impaired glucose tolerance in diabetes. With time, TSH continue to go up, and you start to see drop in T4, and T3 remains normal. This is why T3 is not good for the diagnosis of hypothyroidism. T3 usually does not go down except in the very, very, very late stage, because TSH keep driving the conversion of T4 to T3. And as you know, most of the T3 comes from the peripheral conversion of T4. Therefore, unless T4 is extremely deficient, there is some supply of T3, and T3 does not go down except in severe hypothyroidism. So this sequence is really the natural course of hypothyroidism. Normal thyroid function, subclinical hypothyroidism or mild thyroid failure, then frank or overt hypothyroidism, and severe hypothyroidism. TSH goes up, T4 comes down. Initially, before that, you have TSH slightly elevated, that's subclinical hypothyroidism, but T4 and T3 are normal. So this is natural course. TSH rises first and abruptly in subclinical hypothyroidism, and decline of T4 follows usually after several months or several even years, and T3 is the last one that we should not actually measure. So what are the differences between subclinical hypothyroidism and overt or clinical hypothyroidism? Well, as you know, subclinical hypothyroidism refers to a condition when you have normal free T4, elevation in TSH, usually below 10 or around 10. And this is quite common in a US population. Around 5% or more of the US population are subclinically hypothyroid. And I think the same situation is here. We see a lot of patients with subclinical hypothyroidism. Overt or clinical hypothyroidism is, or as you all know, is low pre-T4, high TSH, usually quite high, more than 10. It could be 20, 30, 100, 150. It is much lower in frequency than subclinical hypothyroidism. In US population, around 1% or less. And I think the same situation. So we are all familiar with this. We know that there is a difference between subclinical hypothyroidism and overt hypothyroidism. Subclinical is mainly characterized by elevation in TSH, but normal T4. And the patient may or may not have symptoms. And as we agreed earlier, symptoms are not very specific. So the presence of symptoms does not indicate that the patient has subclinical hypothyroidism. So let's go back now with this background to our patient, the 44-year-old lady who had fatigue, constipation, weight gain, low mood, and she looked depressed. She had no goiter. And we asked the question, do you think she's hypothyroid? And if you remember, we agreed that symptoms alone should not make a diagnosis of hypothyroidism, but should actually let us or suggest to us or push us to order a lab test. So the question, which lab test should we do? This is a patient who comes to you in the clinic. Should we do TSH, FT4, T3, pre-T3, anti-TB, or ultrasound thyroid scan? I'm pretty sure now everybody is clear about what is the next test, which should be TSH. TSH is an excellent screening test for this patient. If the TSH is normal, essentially we ruled out hypothyroidism and the symptoms are not related. If, on the other hand, TSH is elevated, this patient has hypothyroidism and we should consider the diagnosis and treat her. We may supplement that elevated TSH with FT4 to make sure that she is really hypothyroid. We are not going to order T3 and FT3. We agreed on this. We may actually do anti-TBO antibody just to, again, support the diagnosis of hypothyroidism if TSH is not clearly elevated. If TSH is 100, I don't have to worry about anti-TBO or anything else. It's clearly abnormal. But if TSH is 6, 7, 8, you wonder if this is a real increase in TSH or this is a lab error or this is some variation in the TSH. And therefore, additional evidence from low FT4 or positive anti-TBO antibody will be very helpful. We're not going to order ultrasound thyroid for hypothyroidism. This is not indicated at all. The same thing for thyroid scan. Thyroid scan is indicated for hyperthyroidism, but not for hypothyroidism. So the test is TSH plus minus FT4 plus minus anti-TBO antibody and nothing else. So this is an algorithm that I will refer to again. This is an algorithm that we developed and we have it in a recent publication that we just published a few weeks ago. And I just want to go over it now and I will refer to it again and again. So if you have a patient and you are wondering whether the patient has hypothyroidism or not, you should actually consider screening with TSH in patients with 4 or more of the following symptoms, like our patient: fatigue, sleepiness, cold intolerance, if the patient has goiter, if the patient has dry skin, weight gain, constipation. Those patients, if they have around 4 or more of these symptoms, they may have hypothyroidism. It is not necessary. These symptoms are common, but it becomes actually imperative and important to rule out hypothyroidism in these patients, and we should do plasma TSH. If the patient has history of any of those, they are at increased risk of hypothyroidism. Unexplained stunted growth in child, dementia in an elderly or middle-aged person, or any person actually. Psychiatric disorders are not infrequently associated with hypothyroidism. If there are certain genetic syndromes that are high risk for hypothyroidism, like, for example, Down syndrome, if the patient received neck irradiation, if the patient is taking drugs that may affect thyroid function, like imidazole or lithium, the patient has some dermatological changes, dryness, change in the hair texture or color. Dyslipidemia is commonly associated with hypothyroidism. Cardiovascular disease can be a complication of hypothyroidism or can be aggravated by hypothyroidism. If the patient has autoimmune disease, diabetes, SLE, rheumatoid arthritis, vitiligo, those patients are at increased risk of Hashimoto's thyroiditis. Hypercholesterolemia and hyperlipidemia, infertility or menstrual irregularities are also common in hypothyroidism. So these are the conditions that would lead to screening for hypothyroidism by measuring plasma TSH. We'll talk specifically about pregnant ladies and when to screen them for hypothyroidism or thyroid dysfunction. So leave it for now. So patients with symptoms, especially when there are multiple symptoms, patients with conditions that are associated with hypothyroidism should be tested for thyroid dysfunction. So in our patient that we just described, she falls in this category. She has 4 or more symptoms, and therefore she should be checked for hypothyroidism. So we did her TSH, and it was 7.2 with a normal up to 4.2, so slightly elevated. FT4 is normal, 15 picomole per liter. So what is this condition? I'm pretty sure everybody is saying subclinical hypothyroidism, and it is true. Should we treat this patient? I'll tell you in my practice, and I want this message to come across. I don't usually treat with one reading like this because our labs are not perfect. They can easily give you a TSH level above the upper limit of normal. And the whole idea is this: don't treat the patient without making sure that he has the diagnosis. This is not necessarily subclinical hypothyroidism. This could be a lab error. The patient has no goiter. She has symptoms, but symptoms are not specific. And therefore, when I get a TSH in this range, I don't rush and treat, I repeat, and I do additional things. What I do usually, first of all, I make sure that I examine the patient well and she does not have goiter. Second, I order anti-TBO antibody and I repeat TSH. The whole idea is to make sure that the diagnosis is accurate. If the TSH comes next time elevated, especially if the anti-TBO antibody are positive or the patient has goiter, then I know for sure that this is not a lab error, this is a real number, and therefore this patient deserves consideration for treatment. It's not necessary at this level that you treat the patient, but at least if I am going to treat the patient, I want to make sure that the patient is really hypothyroid, subclinically hypothyroid, and this is not a lab error. Should we treat this patient with this level? I told you what I do. Well, let's talk about subclinical hypothyroidism treatment. So what are the guidelines saying? They are saying that treatment should be considered, not necessarily given, particularly if the patient have symptoms suggestive of hypothyroidism, like our patient, or the patient has positive anti-TBO antibodies, or the patient has evidence of atherosclerotic cardiovascular disease because there is an association between subclinical hypothyroidism and atherosclerotic heart disease, heart failure, or if the patient has associated risk factor for these diseases. So what is the bottom line here is, again, what I just mentioned, and this is talking about TSH between 5 to 10. In other words, mild thyroid failure or mild subclinical hypothyroidism. In this situation, you want to make sure that the patient really needs the treatment, because once you start the treatment, it's always difficult to stop it because you give the patient a lifelong diagnosis. So before rushing and treating patients on the basis of mild elevation TSH, make sure that the patient really has a real disease and not a lab error or factitious phenomenon. What about if the TSH is more than 10? If the TSH is more than 10, it is generally not a lab error. Although we come across patients who have TSH of 12 and 13 and 14, and you repeat and you find it 3 or 3.5. I generally, if the elevation is only mild, I usually like to repeat. There is no rush. Those patients are not going to die from subclinical hypothyroidism. So usually I ask the patient to come back in 1 to 2 months, repeat the test. If the test is showing me the same result and the patient has symptoms, I usually start them on thyroxine. In general, if TSH is more than 10, those patients usually have symptoms. Those patients deserve treatment in general, and it is recommended. So you can see here the recommendation. Patients with a TSH that exceeds 10 are at increased risk of heart failure or cardiovascular mortality. And again, they don't tell you you have to treat them. They said you should consider treatment with L-thyroxine. And this is, as you can see, level B evidence. And they were making even some comments about this, that's not generalizable, and meta-analysis does not include prospective interventional studies. Hypothyroid patients, and they're making another statement, and maybe we can see it in our patients, saying hypothyroid patients treated with normalized TSH are still more likely to feel poorly with subclinical hypothyroidism. So the treatments of subclinical hypothyroidism continue to be an enigma and controversial, but these are guidelines that you should know. If the TSH is 5 to 10, don't rush. Repeat, seek additional evidence, get anti-TPO antibody, examine your patient, and decide on treatment. If the TSH is more than 10, especially if the patient is hypothyroid, is having hypothyroid symptoms, or he or she has goiter, I think your threshold should be lower to give those patients thyroxine. But there is no guarantee that they will do well. Well, going back to our patient with a TSH of 7.2 and FT4 of 15 and many symptoms that she had, she was actually started on L-thyroxine 50 microgram daily. After 2 months, her TSH is perfectly normalized. It's 2.5. However, she does not feel well. And this is again the point that was just mentioned here. Hypothyroid patients who get their TSH to be normalized do not necessarily feel better if the elevation in TSH is only mild, like our patients. So what should we do with this patient now that the numbers look good, but the patient does not feel well? Should we increase the dose and bring her TSH even lower down? Should we add T3? Should we stop thyroxine and replace it with T3 as the active form of thyroid? Should we change the brand of thyroxine? Well, we will discuss this in a minute, but increasing the dose is unlikely to result in any benefit. In fact, you may induce hyperthyroidism with all the consequences. Adding T3, as we will discuss in a minute, is not recommended. Replacing with T3 is not recommended. Changing the brand of thyroxine obviously is not going to make any difference. You already normalized her TSH with the current brand. So what is the point of changing to another brand? Okay, so let's talk now about T3 or T4, T3 combination. There has been some interest in the last decade in using T3 or T3 with T4 combination. But the bottom line, evidence is weak and is not supportive of using T3. So the bottom line, no, we don't use Cytomel or T3 to treat patients with hypothyroidism. And the reason for this is the evidence is basically not supportive. In all the studies that have been carried out to test the benefit of T3, there was only benefit in what is called affective symptoms. Affective, that's basically psychological symptoms. And even those symptoms were not necessarily related to T3. Trials have been relatively short. Studies to date are mixed. Some are showing benefit, some of them are showing no benefit. And meta-analysis, which are considered to be high-level evidence, were negative. Combination therapy is still not yet completely understood in the setting of patient preference. So the bottom line, no T3, no T4, T3 combination in the treatment of hypothyroidism, at least as of today. Studies are ongoing. The debate continues. And maybe in a year, 2 years, 5 years, 10 years from now, T3 might be part of the treatment. But for the time being, T4 is the standard treatment for those patients. And this is actually from the guidelines saying that LT4 is the preferred treatment. That's thyroxine. Patients with hypothyroidism should be treated with L-thyroxine monotherapy. And this is a grade A level. That's a high evidence. Evidence does not support using LT4 and T3 combination to treat hypothyroidism. So I think that's an excellent point that we mentioned. Initiation. Okay, now let's move to another. So I think for subclinical hypothyroidism, we have already discussed when to consider further testing, when to start treatment, and what would you expect from treatment, and also that there is no need to put the patient on T3. Okay, how to initiate and monitor thyroxine therapy? Let's take another case, and we will come back to all of these cases at the end of the talk. So this is a 65-year-old man or lady who is diabetic and hypertensive for the last 15 years. She is severely hypothyroid, and she has small goiter, and her TSH is 110. Now, this patient contrasts very well with the previous patient with subclinical hypothyroidism. I don't need even FT4. This patient, there is no controversy about the need for treatment. Her TSH is very high. She has goiter. There is no question about the need for treatment. So what would you do? Should we get anti-TPO antibody in this patient? No, I don't see any benefit from it. This patient is clearly hypothyroid. What is the reason for her hypothyroidism? 100% or almost 100% is going to be Hashimoto's thyroiditis. She is the right age, the right gender, and Hashimoto's thyroiditis is the most common cause of hypothyroidism, and she is already having goiter and high TSH. So I think the right question to this is to treat her. So what would you use? You will use thyroxine, obviously, and what dose of thyroxine? And how would you monitor this patient? And what is your target TSH? So you may take a minute to think about those questions. What would you do? You will treat or not? I think we already said yes. What is the formula? I think thyroxine is the formula. What dose? We will talk about it, and how to monitor, we'll talk about it, and what is your target TSH. So here is the recommendation again from the guidelines. When initiating therapy in young, healthy adults with overt hypothyroidism, beginning treatment with full replacement doses should be considered. So if this patient was 35-year-old lady who has no other comorbidities, I would have started her maybe on 100 or 125 microgram, full dose, and monitor her TSH in around 2 months. But this is a 65-year-old lady with significant risk factors for subclinical coronary artery disease. She had diabetes and hypertension for 15 years. If you start her on full dose, you may convert that subclinical coronary artery disease to clinical or to angina or to myocardial infarction. And this is why the recommendation here when initiating therapy in patients older than 50 to 60 years with overt hypothyroidism, even without evidence of coronary artery disease, an L-thyroxine dose of around 50 should be considered. In other words, we don't start full dose. You start on maybe half a dose, and you increase it every 2 to 3 weeks until you reach your target. This becomes even more important in patients who are already having angina pectoris or had a history of MI. Those patients probably should be started on a smaller dose, 25 micrograms, and they should be slower and until you attain your full dose. In patients with clinical hypothyroidism, initial thyroxine dosing is generally lower than what is required for overt hypothyroidism. The reason for this is they still have a lot of thyroid tissue there that's producing thyroxine. So if you have subclinical hypothyroidism, you are not going to start on 100 or 150 microgram. You are going to start on a dose of around 25 to 75, depending on the weight of the patient and other issues. and further adjustment can be guided by the clinical response and the laboratory determination, including TSH. Thyroxine should be taken with water in usually 30 to 60 minutes before breakfast or at bedtime, 4 hours after the last meal. This is very important practical point that comes always in the clinic for discussion with the patient. So the best time to take thyroxine is on empty stomach in the morning before breakfast by at least 30 minutes, preferably by more than 60 minutes. And it should be taken with water, not milk, which has calcium that impairs the absorption or even any other things. However, if the patient is finding it inconvenient to take it in the morning, he can take it at bedtime. But usually we recommend to those patients that they don't eat anything for 4 hours before taking this medication. Okay, we'll shift now to another subject, hypothyroidism in pregnancy. And again, I will start with another case. And again, we will discuss these 3 cases later on. So this is a 27-year-old lady who comes to you with no relevant past or family history. She has no complaint. She is clinically euthyroid, completely healthy lady. But she is 8 weeks pregnant, and she is telling you that she read in the internet that hypothyroidism is not good for pregnancy, and therefore she is asking you to check her TSH. So the first question, should we do that? Should we accept her suggestion? Well, here's the recommendation: screening for hypothyroidism during pregnancy. Universal screening is not recommended for patients who are pregnant or are planning pregnancy, including assisted reproduction. So universal and routine screening is not recommended, at least as of this time. When should we screen patients, pregnant ladies, for hypothyroidism? If they have any of these features, if they have family history of thyroid disease or thyroid disease during previous pregnancy, or they are type 1 diabetic or having autoimmune disease, or they had previously history of complicated pregnancy, recurrent miscarriages, menstrual irregularities, or presence of anti-thyroid peroxidase antibodies. All of these conditions increase the risk of thyroid disease and hypothyroidism, and this is the type of patients who should be screened for hypothyroidism, not a completely normal patient like the one we described. Well, under the pressure of the patient, this patient actually had TSH, checked, and it came back actually low, not high, 0.2 micro unit per liter. So what should we do? Does she have hyperthyroidism? Is hyperthyroid? TSH is suppressed. She's 8 weeks pregnant. Well, we checked her FT4 because we want to check on the TSH, on the low TSH, to make sure that this is a real thing. And we found actually that her FT4 is high, 23. So is this patient hyperthyroid? Well, she is biochemically hyperthyroid, but the question, does she need treatment? Well, let's explain this. Why she has those numbers, why FT4 is high and TSH is suppressed. It is actually not because she has thyroid disease or hyperthyroidism. It is because of this. She is in the first trimester, and we know that in the first trimester, beta HCG is extremely high. And this beta HCG has some TSH activity. It is similar in structure to TSH. So it exerts some TSH activity on the TSH receptor. Therefore, it stimulates actually the thyroid to produce excess thyroxine, and the TSH, the endogenous TSH, will be suppressed by the excess thyroxine. So typically in the first trimester, you will find the TSH going down, usually not severely so, only in the low detectable range or low detectable range below the normal level. And that's related actually to increased estrogen and especially increased beta HCG. Actually, estrogen has nothing to do with this. Estrogen has to do with the total T4. total T4 is increased because of the increased estrogen, that's increasing thyroid binding globulin. So total T4 is going to be high because of the increased TBG. TSH is going to be slightly suppressed, and even free T4 can be slightly elevated because of this stimulation by HCG, but this is not indication to treat those patients. This is actually sometimes called gestational toxicosis, and it is more common in patients with hyperemesis gravidarum, and it is mostly during the first trimester, and usually the TSH normalizes afterwards, and the numbers are all normalized. So this is not the indication to treat those patients. What about if the FT4 is 40 and the TSH 0.02? That's not gestational thyroid toxicosis, that's a real toxicosis, that's probably Graves' disease, and those patients need to be treated. But if it is only slight elevation in FT4 or upper limit of normal with a slight depression of or suppression of TSH, this is the reason for it is the HCG. And typically you see this in the first trimester and sometimes early second trimester. Well, what should we do in this patient? Nothing. Reassure her and follow her. She comes back to you at 14 weeks of gestation. That's around 6 weeks later. But this time the picture is different. TSH is 6.1, elevated. And FT4 is 14 on the lower side. Remember, it was 23. And not only this, you did her anti-TPO and it is elevated. So this patient has a real thyroid disease. And currently she is actually subclinically hypothyroid. Now this patient is different from our previous patient who has a TSH of 7.2, and I recommended no treatment for her. This is a pregnant lady, and the pregnancy is different. And she is pregnant, she is subclinically hypothyroid, and she has positive TPO antibody. And we will talk about this. What should we do? Let's make it straight. We should treat this patient. Well, should we treat her? Yes. And should we treat her with thyroxine? Yes. What dose? We'll talk about it. Do you expect her requirement to increase or decrease during pregnancy? I think all of us know that the requirement for thyroxine increased during pregnancy. How frequent should we follow her up during pregnancy? If she has hypothyroidism and you start her on thyroxine, the recommendation is to follow these patients every 1 to 2 months, but at least every trimester. So she was started on L-thyroxine 50 microgram per day, and that's appropriate treatment. She should be started because she has anti-TB antibody. She is subclinically hypothyroid. We know the effect of hypothyroidism on pregnancy. 4 weeks later, her TSH is normal and FT4 is normal, so we are very happy. 8 weeks later, her TSH increased to 4.5, FT4 dropped down because there is increasing requirement of thyroxine with pregnancy. What should we do? We should increase her thyroxine, and that's the case. So let's talk a little bit about thyroxine treatment in pregnancy. First, in terms of the diagnosis, unfortunately, TSH continues to be a good test during pregnancy, but it is not enough. And we need some sort of estimation of FT4. Unfortunately, FT4 that is commonly used in the laboratories is not accurate in pregnancy, and it has so many problems with it. And therefore, some people recommend using actually total T4. But we know that total T4 is increased in pregnancy. So how to do that? You actually should adjust your normal range to 1.5, the upper limit of normal. So if your normal range, for example, for total FT4 is 5, you make your upper normal range 7.5. And anything up to 7.5 is normal, above 7.5 is elevated. From week 7 to week 16, you should increase the upper limit by 5% per week. Once you reach week 16, you fix it at 1.5, the upper limit of normal. So if, for example, the normal range up to 4, for example, or 5, and week after week, you increase it by 5%, and if you reach week 16, you fix it at 1.5, the upper limit of normal. Now, this crowded slide is actually the latest recommendation for treatment of hypothyroidism in pregnancy. And I'm not going to read it because I have summarized it in this table. So what are the recommendations for treatment of pregnant ladies with subclinical hypothyroidism? If the TSH is less than 2.5, don't treat, regardless whether the antibodies are positive or negative. Less than 2.5, no treatment. If it is between 2.5 and 4, which is usually the upper limit of normal in most labs, 4 to 4.2, and the antibodies are negative, don't treat. If the antibody is positive, you may consider, you don't have to treat, but you may consider treatment because the antibody is positive and the TSH is between 2.5 to 4, let's say 3.5, okay? What about if it is more than 4, between 4 to 10? If the antibody is positive, it is actually recommended to treat, like our patient. You remember our patient, her TSH was 6.1 or something like this, but her anti-TBO antibody was positive. Therefore, it is recommended to treat this patient. What about if the antibody is negative and the TSH is between 4 to 10? You may consider, because the elevation in TSH is significant, but we don't have additional evidence for anti-TBO, for thyroid disease. I would not treat a normal person if he has TSH between 4 to 10 and negative antibody, but I will consider treatment of pregnant ladies if she has this situation. What about if it is more than 10? Whether the antibody is positive or negative, it is recommended to treat pregnant ladies with TSH more than 10. So I think this is a nice recommendation. Less than 2.5, no treatment. Between 2.5 to 4, negative, no treatment. Positive, treat. 4 to 10, positive, treat. Negative, consider. More than 10, definitely treat. Last topic here is hypothyroidism and weight. Should we use thyroxine to decrease weight? The answer is no. So, do patients with hypothyroidism lose weight? Yes, if they have a real hypothyroidism, overt hypothyroidism, like the second patient we mentioned, the old elderly woman. It decreases by improving edema. So that's true. But for patients who are normal, completely normal, thyroid function test is normal, or even subclinical hypothyroidism, they usually do not benefit from thyroxine for treatment. This is a meta-analysis of many, many studies showing you that weight loss is not significant. You can see here the summary. Basically, all of those studies did not show reduction in weight if the thyroid function is normal. So no effective, it is not effective weight loss drug, and actually may increase metabolism and increase appetite and increase weight. And it is also harmful for the bone and the heart if it is used inappropriately. And this is actually a recommendation from the guidelines. Thyroid hormone should not be used to treat obesity, as you can see here, and this is important. So the last part of my talk is just to review the cases, just to basically remind you of the cases and solidify what we have just discussed. So if you remember the first lady who came to you, 44-year-old lady, she has a bunch of symptoms. She looked depressed, had no goiter, her TS, and we asked the question whether she is hypothyroid, and we agreed that symptoms alone are not important, not enough, and therefore we should test her with, and the best test here will be TSH, and we did her TSH and it was 7.2 with normal FT4, so she has subclinical hypothyroidism. We recommended that this patient should not be treated immediately. We should repeat the TSH in a few months and get anti-TBO antibody. And if you are seeing anti-TBO antibody positive and TSH is consistently elevated and she has symptoms, maybe we should consider that. There is another question here. What about if her TSH is 16 and FT4 is 13? Probably this patient should be treated. However, if you are cautious like me, I will repeat it one more time. But if you treat her, nobody is going to say this is wrong. So this patient was treated, as you remember, with thyroxine. After 2 months, everything is normal, but she continued to have symptoms. She did not benefit from thyroxine. And we discussed whether should we increase the dose, and we said no, she's already optimally replaced. T3 or a combination of T3 and T4 is not recommended. Changing thyroxine brand is not recommended. The second case we discussed is an elderly lady with high risk for coronary artery disease because of diabetes and hypertension for 15 years. She was severely hypothyroid. She had a small goiter. TSH was elevated. So there is no question that this patient needs to be treated. However, we should be cautious when we start this patient thyroxine. We should give maybe 50 microgram or 25 microgram and increase it every 2 to 3 weeks until you normalize the TSH, because you don't want to induce coronary artery disease that was silent. And your target obviously is normal TSH. What is my target for this patient? The TSH between probably 1 to 3. Okay, and the last case is the pregnant lady who was asking you to check her TFTs or TSH, and we said universal screening is not recommended yet. However, if she has one of the several risk factors, that's recommended. Regardless, this patient was tested. Her TSH was low, FT4 was high. This was because of the high HCG in the early pregnancy and should not be treated because it is only mild elevation FT4, mild depression or suppression of TSH. However, when she came after 6 weeks, she's already having high TSH and of 6.1 and FT4 of 14 and anti-TBO antibody is positive. And this is a recommendation to treat this patient who is pregnant. So she was started on thyroxine, and we need to repeat her TSH is in around 5 to 6 weeks. She came later, and she was starting thyroxine. She came in 4 weeks. TSH was perfect. FT4 was perfect. So we don't need to do anything but to follow this patient. However, 8 weeks later, TSH starts to increase, FT4 starts to drop because of the increasing requirement of thyroxine during pregnancy. What should we do? We increase thyroxine in this situation. So to conclude, subclinical hypothyroidism and overt hypothyroidism are common. As we mentioned, subclinical around 5%, overt around 1%. Symptoms are non-specific. I get always residents and fellows rushing to me and say, we saw this lady in the floor and she is definitely hypothyroid. What is the reason? She is obese, she is complaining of fatigue, she has constipation, she is not feeling good. This is all nonsense. This is all not specific. You should actually do labs in these patients in this situation to confirm your diagnosis or rule it out. TSH is an excellent test in outpatient setting. It's not as good in inpatient setting. We need FT4 usually and maybe anti-TBO antibody. Use lab-based normal range. FT4 is fairly good test with some caveats, especially in pregnancy. T3 and FT3 are not recommended in hypothyroidism. They are used usually in hyperthyroidism to monitor treatment and also to rule or to diagnose the occasional patient with isolated T3 toxicosis. Anti-TBO antibody are useful in subclinical hypothyroidism and in pregnancy, especially because they are going to be important information for you to start treatment in this situation. L-thyroxine is the treatment of choice. No indication to use the combination or T3 alone. TSH more than 10 or TSH of 5 to 10 if the antibodies are positive, preferably after repeating the test, are indication probably to treat those patients. And I just want to draw your attention to a recent publication that we published 1st of June in this journal, Advances in Therapy, and it is about diagnosis and management of hypothyroidism in Gulf Cooperation Council country in GCC. We used actually data, international data, but also local data, and we adjusted the guidelines to our local situation. So this is a review article that I recommend to read, and it is available free, open access on the internet. And you will find this program in which tells you actually when to test patients, when to screen patients with TSH. Merck just sent me those slides saying that they have actually a nice application on iPhone and Android, and you can download it freely. And it actually, it's a beautiful application giving you, for example, the dosing, how to start thyroxine, some useful information about guidelines, and actually even a calculator of the dose depending on the age, gender, weight, etc., etc. So with that, I stop here. Thank you very much for your attention, and I'm ready to receive any question. I hope this was of some benefit. Thank you very much. So I understand from the organizer that they are going to send me the WhatsApp. Okay, so I have a bunch of questions here. Let me answer them. When should we start with 1.6 microgram per kilogram as a starting dose for hypothyroid patients? This is in overt hypothyroid, in a patient with clear hypothyroid, overt hypothyroid, a young or a patient who has no comorbid condition. So if I have, for example, a 40-year-old man, healthy otherwise, and his TSH is 50, 60, 100, this is when I would start him on a thyroxine at a dose of around 1.6 microgram per kilogram. The same dose can be calculated for somebody who's having comorbidities, but instead of starting the full dose, you start with half dose or even a quarter of a dose, and you increase it until you reach your full dose. Okay, how to treat hypothyroidism during pregnancy? I think we spend a lot of time on this, and maybe the question does not need to be answered again. We actually covered this very well into the lecture, and I don't want to repeat this. But for frank hypothyroidism, definitely we'll treat those patients. For TSH more than 10, we will treat those patients. For TSH between 4 to 10, if the antibody is positive, treat. If the antibody is negative, consider. For TSH below 2.5, don't treat, regardless of the antibody. For a TSH between 2.5 to 4 with positive, consider. With negative, do not treat. All right. Can controlled hypothyroidism explain high serum prolactin in a patient with regular use of medication with normal TSH, T4, and T3? If thyroid function is normal, prolactin is not related to hypothyroidism. Yes, hypothyroidism increases prolactin when the patient is not replaced, but if you get a normal TSH, prolactin should normalize if it is due to hypothyroidism. Please, in case of mild elevation of TSH, such as 4.57, anti-ANA that is elevated at 1 to 320, and anti-double strand antibody negative, no symptoms of hypothyroidism. My question: can we treat? And what about the course of this case in the future? Now, this patient, I would like to get anti-TBO antibody, not anti-ANA, because anti-ANA is not specific to thyroid. So maybe the one who asked it was referring to anti-TBO. If the anti-TBO is positive at 1 to 320 and TSH is 4.57, I will not treat this patient. I will not rush to treat this patient, but I will follow her, and she has a fair chance of developing hypothyroidism over time. When should I treat her? If she's pregnant or planning pregnancy, definitely. Or if she is severely symptomatic, I may consider a trial of thyroxine. But if the case is asymptomatic, only the number is 4.57 and the anti-TBO is 1 to 320, I will not treat this patient. I will repeat her TSH maybe every 6 to 12 months. She's not going to develop hypothyroidism in 1 month. It is going to take a long time. She is definitely at a higher risk of hypothyroidism over time, but there is no reason to keep repeating this more frequently than 6 months. What are the possible causes for normal level of TSH and low FT4? Well, if you have that situation, of course, one thing that we have to make sure about is that this patient does not have central hypothyroidism. She or he does not have pituitary tumor or had head trauma. But of course, it can happen sometimes, especially in pregnancy. Pregnancy, you can have actually low FT4 because we agreed that FT4 is notoriously bad during pregnancy. Therefore, I would repeat it, and if it is consistent, I may actually obtain MRI of the pituitary. Okay, can we consider failure to control dyslipidemia in a patient with hypothyroidism as an indication of insufficient thyroid hormone replacement? Yes, hypothyroidism can actually aggravate dyslipidemia. However, if you have a normal TSH, it is not the reason. And the contribution of hypothyroidism to dyslipidemia is modest. So if you have a cholesterol, for example, of 8, and the patient is hypothyroid, this is not actually the reason. This is not the only reason. Hypothyroidism is contributing, but the patient has primary familial dyslipidemia. In other words, do not push the patient to hyperthyroid range to correct dyslipidemia. Correct dyslipidemia by other methods, the anti-lipid medication, weight loss, diet, etc., etc. Okay, is there any rule to use combination T423 in case of hypothyroidism after thyroidectomy? I think we agreed earlier that there is no recommendation to use this combination. I must say that the evidence is not conclusive, but for the time being, the international guidelines do not recommend T3 either alone or in combination, even after thyroidectomy. How long after investigation you would, how long after the investigation be repeated in old age people? I think the question here, in an old age, how long after the investigation be repeated in old age people? I really don't understand this question, but if you mean that an old man or old woman received thyroxine, when should we repeat the test? We should repeat the test around 1 month, around 5 to 6 weeks after full dose of thyroxine. The last question I have here in the follow-up, what is the target TSH for hypothyroidism? Well, it depends. In general, if you have a young patient, I like actually to keep their TSH between 1 to 3. If you have an elderly patient, you may even release it a little bit. So you may say 1 to 4. In general, I like to keep it actually between 1 to 3. In young patients, you may even be happy if it is between 0.5 to 2.5, or in other words, in the lower half of normal range. I think that's all I have, the questions. If there are additional questions, I'll be happy to answer. I hope the session was useful. We have covered many aspects of hypothyroidism, and I'm very pleased that I participated with you tonight. And thank you so much.